Thank you, everyone. This is the last session. The day's been fantastic so far. My name's Helen Reeves, and this is Aileen Marshall. And so this session really is focusing on the surveillance tests. And it's my pleasure to introduce our first speaker, Gabriel Rogers, who's going to talk about the accuracy and cost-effectiveness of the existing surveillance tests.
Okay, thanks. My name's Gabriel. I'm a health economist from the University of Manchester, and I'm going to talk about some work that we've been funded to do by the NIHR. It's a broad evidence synthesis looking at the benefits, harms and costs of different approaches to surveillance for HCC. I just wanted to flag a couple of things on this first slide. The first is the word cirrhosis. We've heard persuasive arguments today that this topic extends more broadly than that. But what we've been funded to do is specifically to look at the evidence base in people with cirrhosis. And the other thing I wanted to flag is this end date, which is in the future, you will notice. So everything that I'm about to present today is work in progress and subject to finalisation and subject to peer review. And indeed, I spotted something on the train on the way down that I already want to revise. So, please interpret everything I'm going to say in that context. So there are four work packages in the piece of work we've been commissioned to do. I don't have time to talk about all of them today, so I'm not going to talk about our work package 1, which is a systematic review of observational evidence looking at HCCs found under surveillance compared with those found incidentally. And I'm not going to talk about work package 4, where we're going to try and wrap up all our work into something that hopefully is helpful to people who are making a decision about whether to start or indeed stop surveillance. What I am going to talk about is a little bit at the end of the presentation on our work package 3, which is a health economic decision model. But most of the time I'm going to spend talking about our second work package, which is a systematic review of diagnostic test accuracy data. So everything in this project is evidence synthesis. There's no original primary research here. It's about identifying and bringing together existing published evidence, and this work package looks at how well the tests that could be used in a surveillance program work. So what we've done, we've looked through a little over 10,000 potential papers, and we have narrowed those down at the widest possible inclusion we could have had was around 800 papers. But we built some flexibility into our protocol envisaging such a situation, and we simply didn't have the capacity to do all that. So we've excluded the less directly relevant evidence, including anything from before 2005 and anything which isn't in populations that have 100% cirrhosis. And that leaves us with 146 papers that form the core of our review. Is some descriptive description of them. I won't go through it all, but worth flagging that the papers come from all over the world, and you'll also see that we've got hepatitis C is the predominant etiology amongst the papers, but there's a reasonable spread of representation in terms of where they come from and how they're set up. What there isn't much of a spread of, I'm sad to report, is the quality of the papers in terms of their susceptibility to bias. When we've assessed that using the regular validated tool that one uses in these types of review, the scores on the doors are not good for the evidence base we've accumulated here. It turns out that the studies are pretty good at describing the tests themselves in that second dimension of the score, but leave a lot to be desired in almost all cases when it comes to other aspects, particularly having comparable patient groups in those with and without HCC, and in how they describe and indeed how they operationalise their reference standard, the ground truth by which we assess whether the tests are telling us the truth. So what have we got? We've got, amongst those 146 studies, a significant majority of them at least contain some evidence on AFP. That's not because there are 116 studies on AFP, it's because everyone is probably able to include AFP results in their study about whatever it is they are interested in. But that's by far the most represented. We have some small collections of imaging data on ultrasound, MRI, and CT. We have we have a selection of like 32 different genomic targets reported across 23 papers. None of them reported more than once, pretty much. And we have a few of these multi-test algorithms, your Gallads and your Doylestown's, and tests that try and pull together multiple markers. So I'm going to show some provisional results here, doing this in receiver operator characteristic space, which almost all of you will be familiar with, but permit me a couple of minutes to just walk through it. So in any test, obviously we're interested in, or most interested in, two dimensions of a test. Firstly, does it identify the cases you want to find? In this case, how good is the case at finding HCCs when they are there? We call that its sensitivity. And secondly, how good is it at not raising false alarms? How good is it at not saying there's an HCC there when there isn't one? And we call that its specificity. And we can conventionally plot this in ROC space like this, with sensitivity on the vertical axis and specificity on the horizontal axis. And a perfect test would sit right up here. You'd have no false negatives and no false positives, and you'd be right up in the top left corner. So how do our tests get on? So to start with ultrasound, each blue dot on this graph represents an individual study. And the first thing you'll see is that there's a fair degree of heterogeneity around them. They cover a relatively large area. The dashed line, which I hope you can see, though it's pale on my screen, represents a 95% uncertainty interval. And you can see it's much more uncertain in one dimension than another. We're relatively sure that ultrasound is a fairly specific test with no more than a 10% false positive rate, 90% specificity. There's much more uncertainty in the vertical axis, in the sensitivity domain, with that interval ranging from below 40 to above 80%. If we look at contrast-enhanced MRI, we do have a couple of studies of non-contrast-enhanced MRI, but not enough to do meaningful synthesis with. There's slightly less heterogeneity here, and we find that our mean estimate is mid-80s percent sensitivity, and similar specificity. And then CT, similar again, but a wider uncertainty interval, largely due to the fact that we've got fewer studies, though we do have one perfect test there in one study, which classified absolutely everyone perfectly. So that's the overview of the imaging studies. If I move on to the continuous biomarkers, and using AFP as an example, because it's, as I say, by far our richest evidence base. If we plot from every single study a point for the sensitivity of AFP as a function of its threshold, it looks something like that. So that every one of those dots represents people with HCC within studies at a given threshold, where what's the probability that their test would come up positive at that threshold. And we can do exactly the same with people without HCC in the same studies, and those blue dots give you the probability that you would come up positive despite the fact that you do not have HCC. So that's like, if we read off here on the vertical axis, that's our false positive rate, 1 minus our specificity. And we can stick some lines through that and come up with a model of a threshold sensitive estimate of the accuracy of AFP. There's still a lot of heterogeneity around these dots, obviously. And one possible reason for that is the underlying etiology of disease. So we had a look at what happens if you stratify the studies according to the predominant etiology within them. And you do get a bit of separation there. Those green lines at the top of each of these are for people with hepatitis C, or rather studies that predominantly have people with hepatitis C. And you can see that it's a rather more sensitive test. AFP is a rather more sensitive test in those people, but also rather less specific, or in other words, people with hepatitis C have higher AFP levels. And conversely, you can look at the NAFLD population at the bottom there, who are both less sensitive and more specific. But I think I can argue that pretty much everything I've shown you is a bit irrelevant for the purpose of talking about surveillance, because everything I've shown you so far is the ability of a test to identify any old HCC. And that's not what we're about here. What we want to do is identify HCCs when they're small, early stage, amenable to curative treatment. So the last bit of synthesis that I'm going to show you is how we've begun to unpick that. So we've been able to do this for 4 separate tests, which are the 4 I've already shown you, and come up with some estimates of sensitivity at various stages, which we've mapped onto something like the Barcelona schema. So among the late HCCs, then you'll immediately see that like, cross-sectional imaging basically gets everything. You're not going to miss a large late tumour. And ultrasound is, well, what's that? That's like 6/7 of people are going to be caught. And by the time you get to that stage, even the sensitivity of AFP is relatively high at just under 2/3. What we're more interested in is the earlier stages. So at the A stage, you can see that the MRI and CT are still up around the 90%, but ultrasound has already dropped off to 60 and AFP has halved. And if you go to the very early, then the sensitivity of ultrasound falls as low as about 33%. And indeed, at that very early stage, at its point estimate at least, it's neck and neck with AFP, though the cross-sectional imaging remains capable of spotting 2/3 to 3/4 of cases at that stage. Okay, that's all I've got time to talk about our work package 2. I want to talk very briefly about our work package 3, where we're feeding that information and other data into a health economic decision model, where we're going to simulate a bunch of strategies that one could adopt for surveillance. I'm not going to talk all the way through this. It's just a picture of something like a schematic of the model we're in the process of building. We are simulating strategies which are multidimensional. So there must be a frequency, there must be a test or tests. In the case of any continuous biomarkers, we specify a threshold and we can vary that threshold. And we're also looking at stopping rules, which we can only do relatively bluntly in what we're doing, but we can certainly do age-based ones and possibly other approaches. We're going to look at stratifying analyses by etiology, which is going to have an influence on the demographics of the population and also the probability of HCC and decompensation along the way. And within that, we think we've got decent evidence to substratify people with viral hepatitis into those who have and have not achieved a complete antiviral response. And we've got functionality within what we're doing to explore the impact of better or worse adherence, which as a little collateral benefit might be able to give us some information about the kind of headroom we've got in the system to pay more to achieve better adherence. Though we are only going to be able to do this in a relatively arbitrary way, we're still keen to explore what difference it makes if you just wind up and down the competing hazards of death that obtain in a given cohort. So yeah, we've finalised our structure. We've completed our parameterisation of that. There's some very clever things that the statisticians I'm working with in Bristol have been able to do in terms of simulating the unobserved natural history of undiagnosed HCC. An outstanding challenge we're facing is how the heck you put a cost on common tests, uncommon tests. If anyone in the room has got any idea what we pay in practice for something like a DCP or even worse, a genomic test, then I'd be delighted to hear from you. Thanks, Ellie. And we're in the process of the nuts and bolts of that. That's me done, except that list of acknowledgements, amongst which at the bottom there is the advisory group who've been invaluable in this process, and a few of whom are in the room. So thank you.